when I was trying to decide what I was going to talk about for this, browsing through the recent journal, topic, I'm afraid. I slightly apologise for the level of detail and tedium that will go with it, but I think it's quite an important topic, and the evidence-based medicine part of me got a little bit excited about the scale and methodology of this paper, because I think it's relatively novel and interesting, and we can talk about that later. So we're going to be talking about post-op nausea and vomiting. Very quick summary, just to say that it's obviously very common. Estimates of around 30% of patients without prophylaxis end up getting some degree of post-op nausea and vomiting, but in higher risk groups, that can go up to sort of 80+%. There's obviously loads of different risk factors that go with it. I've listed just some patient-based risk factors that are very definitively shown to be probably most associated with risk there. But obviously, that's not all there is. There's surgical factors, and there's also kind of intraoperative and anaesthetic factors that go with it. So it's not just about patient risk, but I think those are sort of consensus risk factors that have a very definitive evidence base around them. And we know that getting significant post-op nausea and vomiting is associated with lots of negative outcomes, particularly in a world where we try and move towards doing everything that we possibly can as day case, because it's one of the most common reasons to fail day case discharge. So I think it is important. This is just a quick physiology recap to discuss all the different inputs into this, what's fundamentally quite a complex pathway. And you can see here why there are lots of different risk factors. So the drugs we give, the type of surgery we're doing, the even previous experiences, and the fact that stress surgery is an inherently stressful thing for most people to be going through, all feed in to create a high risk of nausea and vomiting associated with any anaesthetic. And this also kind of highlights the main target pharmacological groups, which we'll come on to when we talk about the paper. So this is the paper I'm going to be talking about, which is a large meta-analysis published in this month's Anaesthesia journal, which is an abridged, thankfully abridged version of the full Cochrane review that Weevil et al. Came out with, basically trying to look at so of all the antiemetics available on the market globally at the moment in common use, what's most effective and what's safest in preventing post-operative nausea and vomiting in the first 24 hours of surgery. And they pulled all the data they could find on individual drugs and combinations of drugs in any combinations against themselves or against placebo. So the background to this is that there are very large numbers of antiemetic medications on the market, licensed to different degrees in different countries. And actually this paper was slightly eye-opening to me, quite the menu of antiemetic medications that are out there, of which
I kind of felt like we can use a lot of them there. I did
yes.
a bit like, you know,
So that's something I'd like, so that's something I'd like to come on to later, is the fact that
all the good ones.
yeah, the good ones we don't actually currently use. But it was eye-opening to me quite how many there are out there, because yeah, I think we sample from a very small menu at the moment. There are a lot of studies, and you'll see the numbers later. There are a lot of individual studies which typically are quite small, looking at different prophylaxis strategies for post-operative nausea and vomiting, but very few of them have attempted, very few studies have attempted to bring together these studies to generate kind of overall guiding principles. A few sort of relatively high quality systematic reviews have tried in those papers listed so the Trico et al. Have looked at efficacy and safety of the 5-HT3 antagonists for all surgery, and that was the best systematic review prior to this. Cho et al. Did another one, but they were looking, they looked at all antiemetics, but only in post-tonsillectomy patients. So there have been some sort of attempts in small patient groups, but nothing broad and globally applicable. And when you try to look at systematic reviews looking at safety, particularly adverse effects and safety, this is really the only one for ondansetron, is the only one that's been done, and that's a topic that we'll probably come back to, because I think it highlights the bias in our clinical studies towards reporting efficacy outcomes over safety outcomes in general. So this was a systematic review and a network meta-analysis. So this is the kind of novel methodological part to this, and I'm going to come back to it because I think it needs talking about separately. It included only randomized controlled trials, so high quality, in theory, high quality evidence published in any language up to April 2020. They didn't include conference abstracts and things that weren't fully published randomized controlled trials. They looked at studies that included any of what they call the 6 recognized classes of antiemetic, and they categorized these according to their method of action. And so those are the 6 classes they've incorporated, most of which we will recognize. The one class people may not have come across in clinical use particularly is the neurokinin 1 receptor antagonists, which are a new class that I think are used predominantly in chemotherapy-related post-op nausea and vomiting at the moment. I think that's their only kind of clinical indication at the moment. But as we'll see later, they actually show quite a lot of promise in terms of their numbers. So we might come back to those later on. And anticholinergics, really the only one that's used as, or was used, is scopolamine, which I think isn't really used in British practice as a antiemetic anymore. So that's a relatively unimportant category as well. The medications had to be administered with the primary goal of preventing post-op nausea and vomiting, so using DEX as a kind of block enhancer or something like that didn't count. It had to be the medication had to be administered during the anaesthetic or before, with the primary aim of relieving post-op nausea and vomiting. And they did not have specific dose requirements. They combined all doses of a specific drug to create one node on their network meta-analysis. They did subsequently go back and do some attempts at sort of retrospective dose response sort of data diving, but that was not the primary aim of the study. So in terms of the population that they identified, so they were looking at only adults, so it's any 18 people age 18 plus, and it was any type of surgery in which the patient had general anaesthetic for the surgery. So it obviously didn't include patients having regional anaesthesia and sedation. So this is when I say there were large numbers, this is what we're talking about. So we've got almost 100,000 patients in 600 randomized controlled trials. So from a purely sort of evidence-based medicine standpoint, that's pretty big numbers and allows you to draw some pretty firm conclusions. The data sets were, I think, fairly reasonably balanced. So these are the sort of baseline characteristics of the patients that included these 97,000 patients. So majority in studies conducted in Asia, but also Europe and North America make up the majority. Middle-aged, predominantly female, predominantly fit and healthy, having a general anaesthetic using volatiles, and receiving perioperative opioids. So a kind of pretty standard model for, I think, most of the patients that we give prophylactic antiemetics to, although we'll come back to talk later about the applicability of this in more general terms and going forwards. Having fairly standard surgical procedures, so gynae and GI, they didn't actually give a breakdown of what the rest of them were, but these are the most common surgical procedures being undertaken. So I think that's a fairly reasonable starting population, which does have relevance to us. So the three primary outcomes: vomiting in the first 24 hours post-operatively, serious adverse events, and any adverse events were the three primary outcomes. So this vomiting first is the efficacy outcome, for which they had 282 trials that provided data, which is 50,800 patients. So again, a big pool. There were 36 different combination antiemetic strategies used in 28 individual antiemetics used in that. And I don't expect you to be able to see this, but this is what a network meta-analysis node map looks like. And I've got a simpler one to show you later to talk about it a bit more. But so this is the node map for this outcome. And each individual point around this circle is an antiemetic strategy, be it either an individual antiemetic or a combination. And if they are connected by a line, it means that they've been directly compared in a study. And the thicker the line, basically, more studies have provided data for that comparison. So you can see which
Is it more patients or more numbers of patients? That's right, it's a study for more numbers of patients.
It's probably more studies actually for this.
Which is our classic.
Yeah. Yeah, it's number of included studies. So yeah, that's necessarily means more patients. But so the bottom line, and if there's a dotted line, it means they've made indirect comparisons. You can't see it so well in this, which ones are dotted and which ones aren't, but the simpler one will make it more obvious. I think this just goes to show you the complexity you can generate with this kind of approach, and how many different comparisons you can make. And this would be very difficult without using this kind of approach. So these were the results. This is a forest plot. So I don't know if everyone's familiar with how forest plots work. Broadly speaking, it compares each treatment strategy, be that combination or individual, against placebo. And if they are equivalent, their relative risk would come out as 1. A relative risk of less than 1 favours the treatment. A relative risk of more than 1 favours placebo. So anything on this side of the line is favouring the treatment strategy in terms of preventing post-op nausea and vomiting. Anything where the confidence interval crosses 1 is not statistically significant. And actually they've put on this a blue shaded area, which is a segment, I think it goes from 0.8 each side of 1, which they consider to be, even if the confidence interval don't cross 1, but fall in that range, they consider that to be a kind of a clinically questionable validity, as in, so it seems fairly arbitrary where you set that line, but that it's not a big enough magnitude of effect to definitively say that it's a good treatment. But what you can see from this, I tried to highlight some of the more relevant. There's obviously, this is not even the highlight ones where which are a bit more relevant to our practice maybe. Reassuringly, some of the combinations we use more regularly coming out reasonably high and favouring the treatment. So this is dexamethasone metoclopramide on ondansetron combination. You can see it quite clearly, significantly less than 1 with the confidence intervals well outside of the zone of equipoise. Metoclopramide on ondansetron, dexamethasone on ondansetron down here, perhaps our most commonly used one. And then this is right, so they're ranked on the full forest plot by their treatment effect, essentially, from most effective down to least effective. And down here with placebo at 1, you can see there's a lot more individual agents. I think this is a recurring theme that we will come back to, is that in general, combinations definitely seem to be more effective than individual agents. And particularly some of the more old-fashioned individual agents like metoclopramide, although doesn't cross 1, it is firmly in this position of questionable clinical significance. Interestingly, cytosine very much crosses 1 as an individual agent, and even on ondansetron as an individual agent.
Teaching?
Thank you.
What I did think was interesting, even on ondansetron as an individual agent, which I think most people would consider to be a reasonable anti-emetic strategy, particularly in maybe lower risk patients, is still considered to be in this zone of questionable clinical significance from their arbitrary setup. So as part of the...
And with ondansetron, when you look at the size of the blob in the forest plot, actually, that is, that's a lot of studies, isn't it?
Yeah, there's a huge amount of studies there, yeah, and it still doesn't firmly move outside of that area. And yeah, so that's the big strength of this, and we can come back to that, is that the numbers are so big that these confidence intervals are actually really good for any kind of systematic review, and allow you to make pretty certain conclusions. And even with that good data, you still can't necessarily demonstrate good effect. So they also, when they were extracting the data for these studies, the authors made an effort to assess the quality of the evidence that was coming out of them. And they did this by basically doing a risk of bias assessment, looking at things like randomization strategies, strategies, how the data was analysed. You can look in individual papers about how, in the actual paper, about how the risk of bias was assessed, but they come out with a rating for the quality of the evidence. And so of the evidence that they rated as at least good or moderate quality, they came out with these antiemetics that have evidence for effective relative risk reduction for post-operative nausea and vomiting as individual agents. So, and these are ranked in decreasing order of efficacy, basically, with fosylprepitant being the most efficacious. And they give the numbers. So there's lots of different ways of trying to kind of present the data when you're looking at meta-analysis like this. But the way they did it is quite interesting. They, instead of a number needed to treat, they've given a sort of hypothetical. If you had 1,000 patients undergoing a general anaesthetic for surgery, you'd expect 300 of those to vomit if given placebo. And if you give the most effective drug on that they found, 282 people of those 300 would benefit from getting it, and only 18 would not, which is a very good willingness to treat. Whereas if you give the least effective droperidol, 117 would benefit, 183 wouldn't. So there's quite a big discrepancy of preventing post-optimal vomiting. I do have some potential issues with this as a way of presenting it, not least because the patient, so that this 300 out of 1,000 suggests that you've got this sort of 30% baseline risk for having post-optimal vomiting, but the patients included in this trial, we've already established, were younger, fit women having gynae surgery with inhalational anaesthetic. So I think the actual risk of having a post-operative nausea and vomiting should, if you, from the generalized literature, be much higher than 30% in that group. And so the numbers might not look quite so good if you had more like 800 out of 1,000 starting with post-operative vomiting. But I think it's just different ways of presenting the same data, really. We spoke about this. So the general theme is that combinations seem to be more effective than individual drugs, but the neurokinin 1 antagonists are possibly the exception to this rule. So if you look at this list here, so these are all combinations. That's neurokinin 1, neurokinin 1, neurokinin 1. So all the, most of the single agents that feature in the top 10 are all neurokinin 1 inhibitors. So the other primary outcome they were interested in was about safety and serious adverse events or any adverse events. And we spoke earlier that how the literature on this is pretty thin, apart from small individual trials. And they found that compared to the efficacy data, the kind of theme was that safety data was much less well reported in all the studies. So of the, whatever it was, nearly 600 randomized controlled trials that were included in the overall met inclusion criteria, only 28 were able to provide data into the analysis of serious adverse events, which still had a number that still included 10,000 patients. But there's a lot of data lost there, and you've got to wonder why that data, which data is being lost, basically. The bottom line is that the data they were able to extract showed no evidence of benefit or harm in terms of serious adverse events when compared with placebo. But the caveat is that the data was of poor quality with relatively small numbers of patients and wide confidence intervals.
And if you think the rate of adverse effects for these drugs, actually,
you'd have to have massive trials.
Yeah.
And that is probably the biggest issue, and why adverse event reporting is harder than efficacy reporting, and it's not as worthwhile for the drug companies.
Well, the drug companies really don't want.
Exactly.
So they don't want to fund
they don't want to fund massive long studies to find all the adverse events. But it is an important clinical question. Slightly better for any adverse events. They managed to find 61 studies that provided data for that. And this is the forest plot for that. So again, this side of one favouring the treatment, as in fewer adverse events compared with placebo. This side, fewer adverse events with placebo compared with the treatment. And the only ones that were significantly worse than placebo were scopolamine and dimethylhydramine, I think it is, neither of which are particularly commonly used in our practice. So I guess that's reassuring in a sense, but I'll just skip forward. But as you can see from this, the data for safety is generally pretty poor. The best quality of evidence they had for any of the safety was moderate, and most of it ranged from very low to low on their risk of bias, and only 11 studies actually managed to rate the risk of bias as low for it. And there are lots of reasons for that, but mostly it was about how the trial was designed to seek information about adverse events, how they followed up patients, whether they even described in the study how they monitored patients. Outcomes where they also possibly hide certain data that more easily, where you can't kind of extract exactly what's contributing to what, which drug is contributing what. So the kind of global message here is that safety data is much less well reported. There were some things that came out where they did some sort of subgroup analyses to look at class-specific adverse events, and I think they do give some relative risks in the paper, but given all the caveats around the quality of the data, I think the numbers are probably not particularly helpful or important, but it is reassuring that they find the sorts of things we'd expect. So they managed to demonstrate a significant association between 5-HT3 antagonists and headache, and they managed to show an increase in extrapyramidal side effects with dopamine receptor antagonists. So those sorts of things, which we would probably expect from our kind of knowledge of the pharmacology, do come out in the literature, but with big caveats around them. Interestingly, DEX seemed to have no effect on sedation, so no negative effect on sedation, didn't make people hyper or anything like that. And interestingly, on danzatron actually reduced the risk of sedation post-operatively significantly. And the other thing to say just quickly is that the most effective treatments, the neuropeptide 1 antagonists, had the least data about their safety, which I think is probably mostly a feature of the fact that they're the newest, and so it's less studies basically. So just to come back to the methodological part of this, so we spoke briefly about the concept of network meta-analysis earlier. I think it is worth sort of thinking about it a little bit. So the idea is that you have, instead of individual treatment groups in studies and then having to combine only treatment groups that are exactly the same to provide a kind of meta-analysis data, you instead generate individual nodes in a network that allows you to compare groups in a kind of hypothetical way that have never actually been directly compared in research. And this is the simplified kind of model. So the idea is that if you've got treatments A and B, A and B and E, say, A and B have been chemically compared directly in a trial, and B and E have been directly compared clinically in a trial. What the network meta-analysis allows you to do is indirectly compare E and A without actually doing a study to do that. By doing this, you can build up a kind of map where you compare essentially every treatment available on the market. And what it allows you to do is generate these kind of league tables without having to do massive direct comparison studies. And this is really useful in areas like this, where you've got lots of options and there's no kind of clear consensus on what the best treatment options are. This isn't the first paper to try to use this technique, but it is relatively novel, and I haven't seen it used a lot previously.
It looks very pretty, doesn't it?
It does look very pretty.
Nice and warm.
You can do the big circle diagrams, and it does look really good. And I think there are lots of anaesthetic. I think anaesthesia is an area where we often have lots of options, and there's no clear consensus about what the best thing would be. And I think even something as simple as analgesic strategies for post-operative pain, you could quite easily imagine a kind of network meta-analysis looking at, for a particular post-operative procedure post-operatively, what all the options were, and then generating a kind of league table for how to manage it. So I think it offers. There are some requirements to be able to do it. So the two requirements they talk about are transivity, which is essentially saying there's no big differences in the patient populations between the groups, such that if you were to do that study, so whenever you're making a sort of indirect comparison between two nodes on the thing, there needs to be no reason why the patients in one node couldn't have had the same, you couldn't have done that trial in reality, basically. So you can't have a fundamentally different patient population in the two nodes, which makes sense. And
But
then
with that, with the post-operative morphine monitoring, the studies are quite different because they have different patient groups that they're testing.
yeah, so they don't talk about exactly
No.
how similar they have to be. I think they talk about it being there has been no sort of direct contraindication to giving the patients in one group the other treatment, which
Yeah, and I was
It's
looking
fair
at it, and I was sort of, it didn't, I didn't feel like it adequately.
yeah, and then the second point is I think is also very much along those lines. So they talk about there needing to be some degree of agreement between the direct and indirect evidence, which means that the example they give is about having a fairly similar, although they don't give numbers about this, I have no idea how you begin to quantify it, treatment effect in similar-ish groups between the two studies. So for example, if you had ondansetron, dexamethasone, and something else in one study, and you had ondansetron and loads of other random things in a different study, and you wanted to compare not ondansetron between those two studies, as long as the ondansetron numbers were fairly similar in the two groups, they consider that to be enough consistency to allow that indirect comparison to be made. But I have no idea how you decide what fairly similar, what consistent actually is, and they don't give any kind of idea about the numbers they use for that. It's possible if you dive down into their supplementary materials, statistics stuff, there's some information about that, but I think while it looks very pretty, there is some, it's a bit of a black box. I don't know how from the average person looking in, I think it's hard to know exactly how they've come to the conclusion which studies are comparable with which studies. Which leads us nicely into the limitations. So there are some limitations here that I've put down that kind of relate both to the systematic review as it is, but also its context to our practice. So as we already mentioned, so most of the patients included in this were fit, healthy, younger, having volatile anaesthetics. And so that doesn't necessarily reflect our patient population completely, and certainly it doesn't reflect the ones where the decision about antiemetic prophylaxis is more difficult to start with. So a much more tricky question is about which antiemetics to use and how many to use in patients with lots of comorbidities, where you start to get relative contraindications or cautions, such as patients with diabetes and giving them dexamethasone and things like that, or patients with slightly abnormal ECGs, maybe slightly long QT intervals, and giving them ondansetron. So it doesn't give us any information to help guide which antiemetic strategy to choose in patients with anything more than kind of simple blank canvas. And given that the safety information in the sort of fit healthy patients is relatively limited, the safety information in unwell patients is going to be even worse than that. So I think there's clearly a limitation in the sort of data as a whole about how to make those risk judgments in more comorbid patients. It doesn't talk at all about the use of trends in recent practice using TIVA as an antiemetic in essence for higher risk patients. So that's a big hole from my point of view. And then this kind of comes back to the point that we briefly mentioned at the beginning, that a lot of these therapies aren't actually routinely used in practice, certainly in the UK, for anaesthesia. And so the relevance of about 90% of those league tables to us is perhaps in question. So what does this mean for us? I mean, I think bottom line I took away from it is it's relatively reassuring. I think what it shows that what most of us do is efficacious and safe from a big evidence base. So dexamethasone or ondansetron in combination, plus or minus something extra, was shown to be both effective and safe in helping post-op nausea and vomiting. So I think that is reassuring. It potentially gives us a bit more impetus to try and get rid of some of the older, less effective things like metoclopramide, which still appear on our day case surgery things, and I don't know anybody who uses it routinely. It gives us good evidence base to say that we should be using combination antiemetics rather than individuals, particularly in patients who are higher risk. And I think it gives, at least opens the question about whether we should be updating the antiemetics we're using routinely to include some of the newer 5-HT3 antagonists and possibly these neurokinin 1 antagonists. Clearly, we don't have any information from this about cost-benefit analysis and things like that. And I also accept that the safety profile of the newer drugs is less well established, but some of the antiemetics we're talking about here, like droperidol and even now ondansetron, are kind of they've been around for a long time, and if we've got newer, more effective alternatives on the market, it seems like that's potentially a direction we should be going in our practice, albeit we're probably not there. I think that's it. So I'd be interested to know what people think. If anybody's had any experience of using any of these newer medications anywhere else, whether I've got any anecdotal evidence of efficacy of these newer things.
Are they routinely using the NK1 antagonist in other countries, or is it not?
So I don't know. So they certainly are using it in oncology settings, where I think it is being used routinely, certainly in this case.
But not in.
But I don't know if it's being used routinely in anaesthetics. It doesn't. So it does have enough. So they give, for example, in the paper, they do give a table of kind of like normal dosing strategies and timing and things like that. So they do have a kind of suggested dosing strategy, timing in relation to surgery and things like that for some of the NK1 antagonists. But it's difficult. They don't give any kind of information about whether it's actually being used routinely by normal people who aren't in studies, basically.
But also, it's really different in the States. We have to bill for stuff, whereas
I think I would doing it in the States.
Though you were saying about the cost and things, actually, if you're going to have to treat 1,000 people to get 180 better, that's an awful lot of cost. And so we're not great at predicting. Obviously we've got those risk factors, but Tuesday want someone who's got no risk factors, I'm not going to give any antiemetic to. That certainly wouldn't be my normal practice,
Yeah.
but would I want to give maybe an expensive antiemetic to somebody
Good stuff.
who might have high risk? I mean, we had someone yesterday who we thought was higher risk, and so we used TIVA for them, but we did dentals, so
Yeah.
just normally obviously I don't use TIVA most of the time. But the dental bit is better.
So sure. The sort of, and I completely appreciate what you're saying there. I think the counter from their numbers, you've got almost like twice as many patients receiving benefit between the best new ones compared to some of the old ones. And so if it were even like twice
Can
as
you just go back to
expensive,
the table of the, if you look at that.
and admittedly they're comparing individuals at this point. So this is fosaprepitant versus droperidol alone, which actually falls right down the bottom.
I think one of the things that they fail to talk about are, so they're just talking about, obviously they've said they often give the giving opioids intraoperatively, but in the first 24 hours, you could also be being sick from other agents that you're giving that are not related to anaesthetic practice at all, or maybe related to the general surgery that you have no impact on, or they've had bowel surgery when they've come to IDS, etc.
So there are lots of reasons why you can end up.
But if you look at that dexamethasone, metoclopramide, or ondansetron, it's actually
It's pretty good.
pretty good and pretty cheap.
Yeah.
So I would almost certainly guess that those will be about, I don't know, 10% of the price.
Yeah.
So the other one, and they're
Fosaprepitant.
more effective.
So fosaprepitant is currently only funded for vomiting post cisplatin chemotherapy.
In this country.
In this country.
Cisplatin are known for its cheap.
Actually, it's only in Scotland. It's not funded in England.
But I'm so old that I remember when ondansetron it's like that, and just oncology got to use it way before everyone else. And so once these things come off license,
then
the cost will drop, and then we may be able to kind of think about using them. And also the knowing about whether they are good in combination or not, because you say obviously at the moment they're simply a lot less. But I think your point was really made about the safety profile of those, because every new thing that comes along looks great for a while, and then once you've given it to 100,000 people, you notice the 20 side effects or side effects for those. And then we get really excited about it. Stop using it altogether, like,
Because I think it's really useful to know actually from data from 100,000 people that when we combine that on Untitled, the risk ratio is 0.3, because that's the most up-to-date data, probably the biggest cohort of patients that we've got. So I think that's a number I want to take away and have in my head. If someone asks me, why are you giving me those 2 medications? So, but I think I completely agree with you on the second point on the limitation that for me, giving 88% of ASA1 to patients a volatile anaesthetic probably reduces the
practice.
Exactly. I think that's the biggest problem with that whole thing.
Agreed. The absence of, so some other studies that I looked at had tried to, or some of the systematic reviews I looked at, so like that CHO one post-tonsillectomy, they had tried to include propofol TIVA as a kind of load on an antiemetic strategy, but they made no attempt. An interesting absence of making it, because you would think that at least some of the newer randomized control trials that have been done have tried to answer that question. And since they've included so much other data, I don't know why they clearly consciously chosen not to include propofol as a antiemetic strategy.
I think it's really difficult as well, isn't it? It's like we were sort of saying yesterday, but obviously you didn't get to do your inhalation induction because you were too good at putting cannulas in all the time for everybody. And with this, if you're using TIVA, you probably don't get quite enough numbers of people being sick to make it like a useful study, because you need lots to be sick in the control group to make it worthwhile.
But then
You just
wouldn't,
got milk in one of them.
Yeah. I'd be not.
Good milk.
but then by that, like, wouldn't you, if you have studies that use TIVA as a intervention, wouldn't you then see TIVA's benefit? I don't know.
But you do, the evidence is that the same.
Yeah,
Treatment intervention. But you want your control, if you're running a study, you want your control group to have lots of volunteers.
Why they're high risk patients.
Yes, hybrid patients, I think anaesthetics don't make
Yeah.
Whether that ethically feels like the right thing to do or not is a slightly different matter, but then we give so many people anaesthetics that we think will make mistakes, so maybe it is.
Cool, thanks, Chris.
Thanks, Chris.
Thanks, Chris. I'm going to stop recording. Susie, do you have any thoughts or do you want to comment? I'm going to stop recording. Thanks a lot, Chris.